Wash RBCs in leukoreduced, where they wash out the proteins to stop sudden urticarial reactions, stops febrile non-hemolytic reactions, filters out the cells, sort of filtering out the white blood cells. Pretty much every blood bank does this now. Never ABO typed. So what is never? PCC, we talked about this prothrombin complex concentrate, or 4-factor, does not need to be ABO typed. Platelets do not always need to be ABO compatible, last longer if they are. I want you to do a quick statement about platelets. Platelets are kept at room temperature, and if you go into the blood bank, you'll literally see them in a machine, usually on a counter, and they kind of swish back and forth like this, swish back and forth the platelets. They have increased risk of infection. Of all the blood products we give, platelets have the highest risk of infection. Remember, they're in room temperature, they're swishing back and forth. Now let's talk about irradiated blood product. It stops the white blood cells from damaging the recipient, can have a version of graft versus host. So who needs this? Irradiated product is basically, they put the RBC and they have a little radioactive vault. You can't believe this. In your hospital, in the blood bank, they're gonna have a little radioactive vault if they're serving or giving irradiated blood products. And you get this little bit of radiation in there. It stops the RBCs from damaging the recipient. It can have a version of graft versus host, as we discussed. Who needs this is bone marrow transplant recipients, acquired or congenital cellular immunodeficiency. So if somebody is on active chemotherapy, you may have a discussion with your hematologist, oncologist, if this patient needs to have irradiated blood. Now, why don't we irradiate all the bloods? Because it costs more money and it slows down the process. So patient has a massive transfusion. They receive 6 to 8 units of RBCs. What is most likely to occur? So what would be most likely to occur if someone receives a mass transfusion? Hypocalcemia. So the blood is stored with citrate, and that stops coagulation in the donor's blood. It's an anticoagulation in the donor's blood. And the citrate can bind to calcium, and you can have a drop in your calcium. So if you're getting a whole bunch of blood products, you can have a drop in your calcium. Calcium gets the coagulation cascade started, so that's why they have the citrate in there, binding calcium to stop the clotting cascade from occurring. Erythropoietin stimulating agents. We're not just talking Tour de France here and cyclists, we're talking about the real world. And let's get right here. And let's highlight that. We promote RBC production, increase of cerebral infarction, increased risk of hypertension, can have vascular access thrombosis in those with anemia of chronic kidney disease, increase venous thrombus, and mortality in those with cancer. So EPO is not perfect. You also have to remember as EPO, you have to have sufficient iron stores, maybe a little bit above, because it's gonna decrease. So if you have low, you're not gonna be able to make the RBCs properly because you're missing that vital element. Platelet transfusions. Platelets are usually a 4 to 6 combined donors, and those are pooled versus single donor platelets. Usually the normal is going to be 4 to 6, and there may be a special circumstance where single donor platelets are needed. Random platelets are expected, so the randomized packets are supposed to increase the platelets by 20 to 30,000 units. Single donor allows a more precise HLA type matching and ABO group matching. Prophylactic transfusions, as we discussed, less than 10,000. Consider this for central line placements, greater than 20,000 for central line placement, and above 50,000 for lumbar puncture. Now, we're talking about low platelets. Let's talk about a disease right here. Let's talk about TTP. It is a thrombolytic microangiopathic anemia. So it's thrombotic, thrombocytopenic purpura. So what can be seen in this is micropathic hemolytic anemia. So what will we see from that? From micropathic hemolytic anemia, we should see schistocytes on that. Should we see increased LDH from the breakdown product? You can have severe thrombocytopenia and ischemic organ injury due to disseminated platelet-rich microthrombi. You noted for Adams 13 deficiency. All right. We'll talk more about this. I just want to kind of get this into your brain. That's where we say things multiple times, and we say it in different ways to find a way to get it in your brainstem and to get it in your brain so that you can pull it out later. So we're going to have schistocytes, increased LDH, we have decreased haptoglobin, we'll have normal coagulopathies on our tests, and we need to exclude other causes of microcytic anemia. It's confirmed with Adams 13 activity less than 10. Now let's talk about fresh frozen plasma. It's made from whole blood, collected through apheresis. So they're taking the whole blood product from the donor and they're apheresing it. And then it's stored at negative 18 degrees Celsius within 6 to 8 hours of donating. And it contains all the coagulation factors, all clotting factors except 8 and von Willebrand factor. And you're going to remember 8 and von Willebrand factor, they're going to go hand in hand together. It's frozen to rapidly preserve the coagulation factors. They can decline rapidly, and it contains the procoagulant and anticoagulant proteins. 1 FFP can have a volume of 200 to 280 milliliters of volume. Usually effective dose is going to be 10 milliliters per kilogram, and excellent for treating multiple factor deficiencies and significant bleeding. Can be given every 8 to 12 hours based on the PTT time. Now what's cryoprecipitate? Manufactured from FFP that is thawed, leaving factors 8 and 13, fibrinogen and von Willebrand factor, and it's going to be in a 10 to 20 milliliter per unit. It's very concentrated. It's usually very small bags when you see it in the hospital. Contains fibrinogen in a more concentrated form. Pooled 8 to 10 units. Can be used as a source for von Willebrand factor, but preferred to use factor 8 or von Willebrand concentrate for von Willebrand's disease instead. We have better factors now and easier to get, and we'll have them in the larger hospital systems. So you don't have to use it for that unless your system doesn't have it. What is it used to treat? Fibrinogen deficiency. When would this be? When we're having dysfibrinogenemia. We can use it for factor 13 deficiency, but mainly you're going to use it for this. You're going to use it for DIC. DIC, this is the big one, is for DIC, is when you're going to use it in the hospital. During RBC transfusion, patient has chills, fever, dyspnea, back pain, and dark urine. What is the likely reaction? It's going to be whole blood group ABO incompatibility. They're having almost like a rhabdomyolysis. They can have hyperkalemia from the death of the red blood cells, renal failure. You need to stop the transfusion, renal failure, stop the transfusion and inform the blood bank and hydrate the patient. So whole blood group ABO incompatibility, we'll consider like a rhabdomyolysis, is they can have hyperkalemia. Remember, with hyperkalemia, we can have a horrible tachyarrhythmia and death. They can also develop renal failure. You need to stop the transfusion immediately, hydrate the patient, contact the blood bank. They're going to tell you the exact steps to do, what vials to send down, and what to use for these patients, what to do next. How to recognize a minor blood group. This would be the Kell, Duffy, Lewis, Kidd, RH incompatible donation. Minor blood groups refer to the red blood cell antigens other than the major ABO. There's over 40 human blood group systems and hundreds of individual antigens that have been identified. It usually happens after several days, and it's delayed jaundice. This is through a cross-match minor groups to make antibodies, and it takes several days to get jaundice. What is the treatment? There is no treatment. This one is going to happen over several days, delayed jaundice. So the answer is happens after several days, delayed jaundice. Which transfusion reaction happens the fastest? Okay, what would that be? IgA deficiency reaction. You have preformed antibodies against IgA, happens faster than ABO incompatibility. This is a severe reaction that can occur within IgA deficient individuals who have developed anti-IgA antibodies. So basically they have preformed antibodies, they're getting IgA, and then they have this instantaneous reaction. When they receive blood products containing IgA, there's an allergic response and can lead potentially fatal anaphylaxis. All right, let's get on a case study here. This is a 76-year-old female with mechanical heart failure, slips on ice and falls and hits her head. So what's important about a mechanical heart valve? Mechanical heart valves have to have anticoagulation, correct? And what is it going to be? Is it going to be a DOAC? No. This is where DOACs do not work in the studies. They caused harm. So what would it be? Is warfarin. So we know that this patient is taking warfarin or should be taking warfarin, and they've fallen and they hit their head. So what do we have? We have a subarachnoid hemorrhage. Hers is going to be traumatic. Traumatic. We know that she fell and hit her head. Traumatic subarachnoid hemorrhage. We have blood in the subarachnoid space. So let's talk about 4-factor prothrombin concentrate. This is a concentrate that contains 2, 7, 9, and 10. This is indicated for warfarin associated bleeding. You also want to give the vitamin K. Remember, you give the factor 4 prothrombin concentrate. It takes down rapidly, but then it can tail back up the INR. We're talking about the INR dropping and then comes back up. If we give the vitamin K takes longer to act, so we're giving the initial prothrombin complex, and then the vitamin K hopefully smooths it out. Does not have to be cross-matched. If unavailable, can use FFP or 3-factor plus 7 supplement or FFP. Remember, it's 2, 7, 9, and 10. Now, this was not originally designed for DOACs, but it can be used on a DOACs as a direct oral anticoagulants. This can cause thrombotic events, so it can cause, it can stop the bleeding, but also cause a thrombosis. All right, so this is a 19-year-old female with extreme, so female, okay, that's important. So we have a 19-year-old female, we're talking blood, male versus female, very important. Extremely long, heavy periods, bleeds after brushing teeth, frequent nosebleeds. So she's having long periods, she bleeds after she's brushing her teeth, and has frequent nosebleeds. What are we looking at here? It's a female, so we would consider what? Von Willebrand's disease. Von Willebrand's act as a bridging molecule for normal platelet adhesion. So her platelets aren't adhering because she's brushing her teeth and she's bleeding. And an aggregation as a carrier for the factor 8. They go hand in hand. Factor 8, von Willebrand. Peanut butter and jelly. Peanut butter and jelly. Factor 8 and von Willebrand factor. Factor 8, von Willebrand factor, peanut butter and jelly. So von Willebrand factor increases the half-life of factor 8. Manufactured by megakaryocytes and endothelial cells. Primary deficiency or defect in von Willebrand factor can have low levels of their carrier of their factor 8. Factor 8, remember it's a carrier of von Willebrand factor. Carrier of von Willebrand factor. So in these patients, you have increased bleeding time. Now that's an old test you don't see much anymore. It's where you cut somebody and you see how long they bleed. Wouldn't you like to do that to somebody? Some of your hospital administrator cut them and see how long they bleed. You're going to have increased bleeding time and PTT. Normal PT, you can have mucocutaneous bleeding and bleeding after surgery and trauma. Most common inherited bleeding disorder. This can be 1 in 1,000 people affected with low von Willebrand factor levels. 1% of those having mucocutaneous bleeding problems. Usually present with nosebleeds, easy bruising, bleeding gums, and post-surgery bleeding. So what's a good test that a lot of people have? What can you ask them to say is, and you would know if they had a bleeding disorder? What would be a good example? What thing did you ask them? Have you had your wisdom teeth pulled? Okay. When you had your wisdom teeth pulled, did the dentist or the orthodontist or the surgeon, the oropharyngeal surgeon, did they say that you had some sort of problem with your bleeding? Okay. Did you have where they had excessive bleeding? Did they mention that to you? So when a tooth extraction, because if somebody presents with a tooth extraction and they have a deficiency, they will have a high risk for bleeding. Von Willebrand factor, menses with 10 to 30% of women with menorrhagia may have von Willebrand's disease. Menorrhagia may be treated with tranexamic acid or apochranoic acid, which inhibits the lysis of fibrin. It blocks the plasmin during menses, so this can be used for them during menses. We also use these tranexamic acid. We can use these in bleeding events. Amycrepic acid. This can be used if you're putting in a central line, as it usually comes in a liquid form if you have it in your hospital system, and you can soak it on a gauze and put it on there to help with bleeding when you're doing central lines. If you're having one that's oozing, is it perfect? No. Multiple types of von Willebrand factor, but type 1 is the most common type. Now, individuals with O-type blood, 25% less von Willebrand factor than other types of blood. So how do we diagnose von Willebrand's disease? We have decreased von Willebrand antigen, decreased factor VIII, decreased racemic cofactor activity. Racemic cofactor measures the ability of the platelet aggregation, and it's an artificial endothelial surface. What can be the treatment? What can be the treatment for this in excessive bleeding? Can be what? Desmopressin. All right, so this is an 18-year-old male. So this is different. We had the female before, now we have an 18-year-old male with some unknown bleeding history, bangs his knee, and has extreme swelling. No, so just think about this. Unknown blood history, bangs his knee, and has extreme swelling. Now think this is not normal. Just think, how would football games be every Friday and Saturday, Sunday night if the participants, they banged on something, and all of a sudden they have extreme swelling in their joints? How well would these games go? Because this is not a normal thing. This is where you have to think about this person has a disease. So this is hemarthrosis. All right, so this is a special consideration, needs to be considered with patients with hemarthrosis, and they have to consider that they have hemophilia. This is a coagulation factor specific for hemophilia, should be infused promptly at the first sign of joint bleeding. So hemarthrosis is a big deal. Now, is this only in males? Because we made kind of a big deal about this. We said this is a male. Very high preponderance of hemophilia being in males. Females can get the disease, but it's very rare. They showed that in 2021, a US study showed that about only 18% of hemophiliacs were females, but only less than 1% of all hemophiliacs that were females had a severe bleed. So very low preponderance of females having hemophilia because it's on the X-link, and we'll talk about this. It's an X-linked disease because they have two X's, so they're less likely. So it's a very low percentage, but yes, females can have hemophilia. All right, let's talk about hemophilia. Hemophilia, the term of hem or blood or bleeding. Philia means affection or love. So blood-loving, hemophilia. Delayed bleeding and deep-seated bleeding. Fibrin is made by the coagulation cascade. Fibrin stabilizes the clot. So the body isn't producing enough clotting factors, and can be very specific ones. Most hemophilia is genetic, caused by mutations in genes for either factor 8 or 9, which are located in an X chromosome. So this is why female patients have 2 X chromosomes, males only have 1. So they have to have hits on both chromosomes for females. So remember, just the amount of females that can have hemophilia is much lower than men. Yes, can they have hemophilia? Much lower amount. So hemophiliacs have insufficient clotting factors like 8 or 9, which lead to reduced thrombin generation, which results in less fibrin being formed. Remember, we have fibrin is made by the coagulation cascade, and fibrin stabilizes the clot. You have significantly weaker fibrin clot that is unstable, permeable, and easily lysed. Diagnosis of bleeding disorders. We have hemophilia A, which is X-linked recessive, seen in males. Females are carriers. Can they have disease? Yes. So we're talking about bleeding into the joints or muscles, and factor VIII transfusion to increase levels by 15% for mild bleeding and 50% for severe bleeding. So using these factor A transfusion in hemophilia A,